Do not always believe what you read. Today, I have a great case that I was involved in to kickstart the progress note. It was an elderly woman, history of congestive heart failure, weakened heart, dementia, stroke, coming in, out of breath. She was actually here a couple of days ago, agitated from her dementia. The ER worked her up, made sure nothing else was going on, and finally made some medication adjustment, calmed her down, and she went back. But then she came back, difficulty breathing, some coughing, and her chest x-ray looked like this. Mind you, normal chest x-ray looks like this. And what you can see is that our lungs are relatively black. A little bit of lung markings, but essentially black. And this is in stark contrast in terms of what her lungs look like right now. This is what we call a complete whiteout. And as an internal medicine physician who hospitalizes or specializes in hospital medicine, also known as a hospitalist, we live and thrive off of frameworks, differentials. And we think of three big things when we see this. One, is this a pleural effusion? Fluid in that lung cavity where it doesn't belong. Number two, is this a lung infection, a pneumonia, where the lung filled with pus, bacteria, inflammatory cells? Number three, is it a complete lung collapse, or what we call complete atelectasis? Thankfully, in my specialty, we get to rely on others, on other people who know more than we do. So our radiologists who reads chest x-rays, tons of them, experts at them, read our film and actually read it as a large pleural effusion. And bam, as a hospitalist, I knew exactly what this patient needed. She needed a thoracentesis. This is a procedure where we stick a needle, a catheter, inside that lung to drain it. To one, make her feel better, but two, to analyze it, figure out what the heck is going on, what's causing this. Thankfully, we paused. Thankfully, we took a moment and said, hey, let's look at a prior chest x-ray. The one that she actually had a couple of days ago when she was in the ER for the agitation. Because that x-ray looked like this. And as a reminder, this is what her current chest x-ray looks like. And you can see the positive red arrow sign that is there. It's pointing towards the trachea. That's the main windpipe feeding into both lungs. You can see a couple of days ago that trachea looked pretty centered, pretty midline. And now the trachea looks like it's being pulled, looks like it's being yanked towards that opacification, towards that whiteout. That does not look like a pleural effusion, because that's not how pleural effusion behaves. When you see that trachea in a complete whiteout going towards that opacification, towards the whiteout itself, you got to think complete lung collapse or atelectasis. And thank goodness we had that pause, because with that, I was like, we got to call our friends, the lung doctors, the pulmonologist, stat, and they reviewed the case. They agreed. The patient did decompensate, unfortunately, and required her being on a ventilator, but eventually got that bronchoscopy, which is a procedure where the pulmonologists are able to look into the airways, figure out what's blocking it, and actually treat it. And thankfully, in this case, they did just that, because this is the outcome. Those are some happy lungs right there, because what they found was mucus plugging up that main airway, feeding that left lung, causing it to completely collapse. And when they sucked it out, that's the chest x-ray you see. You can see that trachea looking so much more midline. I want to take a step back and reflect on this case, and this is, why I wanted to do the progress note for this reflection, and just to be able to kind of process everything, learning points, how we feel during the case. And this case actually had so many different layers to it, great learning points. And I think the first one is, have a framework, right? When you see a complete whiteout like this, think pleural effusion, think complete atelectasis, think really bad pneumonia, right? And let the history, physical exam drive that. Because point number 2, so crucial, look at a past chest x-ray, right? So that you could compare, contrast. Because in this case, it gave us a wealth of information. It really honed us into that trachea. But you can see that it clearly was deviated from her prior chest x-ray, which really allowed us to kind of figure out, man, it is going towards the opacification. So when you see that trachea moving towards that complete whiteout, you gotta think, man, is this complete atelectasis or lung collapse? Now, if you see that trachea moving away from the opacification, away from the complete whiteout, then you gotta think pleural effusion, which is like this. This is a patient I had who had really bad liver disease, what we call cirrhosis, leading to fluid inside that right lung. And you can see that trachea moving absolutely away from that complete whiteout. And I think number 3 learning point is a little bit harder to grasp, in the sense that sometimes it's very hard to go against an expert assessment, a consultant, in terms of what they're saying is going on. And in this case, it was the radiologist, right? The radiologist said this is a large pleural effusion. And you can imagine, if we did a thoracentesis in this case, it would have been disastrous, right? This patient would have had a huge bad outcome because of that. And the learning point is that we're not perfect. I'm not perfect. Radiology is not perfect. They're gonna make bad reads or incorrect reads. But a learning point from this is that as the clinician seeing the patient, as the physician seeing this patient, examining this patient, knowing this patient's history, we have to be more detailed, and we have to be able to process all that and connect those dots, because that's what we're here to do, and be able to integrate all the information to come up with the analysis that we did was such an important one for this patient. And I hope you guys had some learning points from today's progress note. And if you like it, please subscribe. Please share this, because hope to make more. Because we really want to be able to make a positive impact with these patient experiences, because there's plenty of them. And that's today's progress notes. See you on the next one.